going to start here with this practical session is the cecum and appendix. The clinical problems related to the cecum and appendix are of prime importance for the examinations and our life as well. And we have to identify this particular feature which is related to the cecum appendix for the practical sessions as well. Now we have intestines, right? And it is divided into two parts. We call them as small, other is known as large. Large is wider, small is smaller. Lumen is kind of like which is narrow, and larger is having lumen which is wide. But beside that, the large intestine have got some features which is not present in the small intestine features. So large intestine have got three features that you have to memorize, remember. So whenever you are given in the practical exam, they ask about how to identify the parts of the large intestine. Well, they look like large, that's why we call them as large. They don't have any mesentery to it as such, like the way the small intestine have. But the large intestine have got some features. Of course, of that we call them as sacculation. Is the first thing. What do you mean by sacculation? It looks like having some kind of bend. So the large intestine, if you look that, it looks like having some kind of constriction part on these edges. So this kind of constrictions and then dilatations, we call them as sacculation. So this is a feature which is present in the large intestine, which the small intestine do not have it. So sacculation is a feature which large intestine has, which is known as constriction as well as dilatations. So narrow part. Second feature, we call them as a muscle band, it exists on it. We call them as Tenia Coli. So this Tenia Coli is kind of a band, just like a ribbon which is running all across the length of this large intestine. We call them as Tenia Coli. There are three such bands are there, three such ribbons are there. Alright, so if you count the number, three of them. So thus disregard the number. So we have to know this word, which is a muscular band running longitudinally throughout the length. We call them as Tenia Coli. These are the basic thing. Third thing about this large intestine, which has some kind of external attachments of fat pouches. So we call them as Epiploicae. We call them as Tenia Epiploicae. So we call them as Tenia Epiploicae. So which is a kind of serous layer which is present outside to it, right? On the serous layer we see a kind of small pouches of pockets of the fats are there, which is a fat content which is lying in this particular outer layer, which is present in these layers of this large intestine. So this particular large intestine having this particular feature. Now large intestine begins on the part which is a little bit dilated, where this particular small intestine ends and large intestine begins. We call them as ileocecal junctions, which has guarded with the valve. We call them as ileocecal valve. And then we have a beginning of this particular large intestine. So beginning part we call them as cecum. The cecum may not have got all these features existing on it, but it's considered as the parts of large intestine. So anything beyond this particular ileocecal valve, we call them as large intestine. We start with this particular dilated part, we call them as cecum. And then we have this colon which is climbing up, we call them as ascending colon. Then it is turning, we call them as transverse colon. Then it is again dropping down, we call them as descending. Then it is curving, we call them as sigmoid. Then it is dilated, rectum, and then anal canal. Like way it is going on. So all these parts that we are saying beyond cecum, it's a part of large intestine which has a common features of this. Three of them: fat, muscular band, constriction and dilate. These are the things that you have to utter in the examination. You must come and utter these words to pass in examination. Don't speak. You are going to utter, not uttering this word, going to pass this examination. So large intestine is separated from the small intestine having these three features. Clear or not? Good. Then this particular dilated part, large intestine, has an important valve. We call them as ileocecal valve. That means the cecum and this ileum has a junction. That means small intestine ends, large intestine begins, which is guarded by a horizontally placed valve. We call them as IC valve, ileocecal valve. This ileocecal valve basically regulating the flow of this fluid or flow of the content of the small intestine which is moving to the large intestine. And all these things, climbing up, transverse, going down, is controlled by the movement we call them as peristalsis. We call them as peristalsis, which is a movement which is generated from the esophagus going down all the way, stomach, small, large, all the way going down to this particular rectum and anal canal. If we have a reverse flow, we call them as anti-peristalsis. Peristalsis and anti-peristalsis is governed by or controlled by this muscles of this particular small and large intestine, which is also innervated by the nerves. We call them as enteric nerves. The enteric nerves are of two types, myenteric and Auerbach plexus, which is having a cell. We call them as ganglion cells, which discharges along with the tentacles of these fibers are there, which is nerve fiber, is innervating this longitudinal circular muscles, and they are making the contractions. In a likewise they are pushing. Now this particular element, which is known as cecum, which is a beginning part, at this junction or ileocecal junctions which you are seeing here, on the posteromedial side we have a pouch or diverticulum. So that particular pouch looks like a finger. That finger like projections or diverticulum or blind diverticulum. What do you mean by blind? That means end of road. You go and hit there and no more room is there to go beyond. That means it is a covered having a blind pouch. How this blind pouch is directed? Posteromedial aspect of the cecum. So if you are opening this abdomen, once you open the abdomen, you open into the sac. What sac? Greater sac. Once you go to the greater sac, we call them as this particular region, we call them as right iliac fossa, where this cecum is placed. So on this right iliac fossa, you are going to find this dilated part. Then once you find that, where are you going to see this particular appendix? Posteromedial. That means you have to lift this and this see posteromedial side to find this particular organ posteromedial. Now this particular posteromedial attachment of this particular organ is there, blind pouch like organ, diverticulum, we call them as appendix. This appendix have got few parts. Where it is attached, we call them as base. We call them as base of the appendix. Cannot forget about base of the appendix. Then we have this particular part which is ending on this side, finger end, which is known as tip. And then we have the body of appendix placed. So these are the three basic parts of appendix: base, tip, in between, body. These are the three basic parts of this appendix. Now this appendix may be directed in different directions. How this appendix is directed is governed or classified where the tip is placed. So base is more or less in a constant position, but the tip is variable. So if the tip is directed on different directions, we call them as different positions of appendix. So whenever you are going to study the different position of appendix, that you have to study. Now it can be in front of the cecum, it can be on back side of the cecum. So we call them as a retrocecal position of this appendix, which is most common. So this tip along with the base, if it is behind the cecum, we call them as retrocecal. So out of that we have to remember this particular position, R-E-T-R-O, retro means behind. So this retrocecal position is most common positions of this appendix. What do you mean by that? Base is on the posterior side, so is the tip behind it. Now this particular appendix may be directed towards this downside. The tip is projected down. Then we call them as pelvic position, directed towards the pelvis. We call them as pelvic position of appendix. These are the by far the common positions of the appendix which is present. Retrocecal and the pelvic positions are common in terms. Out of this, retrocecal is the common, like more or less 60% or more than that as well. 60 to 70% cases we see that it is retrocecal in positions, which is commonest. That means behind the cecum, and tip is also behind the cecum. Retrocecal. Then we have uncommon positions of this particular appendix as there. We call them as pre-ileal, post-ileal. That means in front of the ileum and posterior to the ileal. That means pre-ileal and post-ileal position. These are uncommon positions, not that popularly seen. In front of it and posterior to it, which is adjacent to the cecum. They are placed. Now, how this particular position is directed, or we are going to nomenclature it, how the tip is, not the base. So, this is tip. So, if the tip is in front of this particular cecum, prececal, postcecal. If it is on the back side, retrocecal. If it is downside, pelvic, etc., etc. Clear or not? There are other positions of this particular appendix also there, but all of that are there, but this retrocecal is the position that we have to remember. Clear or not? Now, coming to this particular appendix, it is a kind of blind pouch, and this particular pouch which is covered by or having a strip of mesentery, we call them as mesoappendix. We call this appendix covered with this peritoneum fold, we call them as mesoappendix. Now, this mesoappendix is a membrane, double layer membrane peritoneum fold, which is covering this particular appendix from base to tip. Now, significance of this particular mesoappendix is that mesoappendix is having blood vessels placed in it. So, whatever the arteries and blood vessels or veins are there, which is supplying this particular appendix, are present on the mesoappendix. Clear? So, we know this particular word as mesoappendix. Now, if we give you a clinical case, like if surgeon is working on the appendix and they find it is diseased, and while a diseased appendix they want to remove that, and while removing that they want to search for the blood vessel which is supplying this appendix, where she should be or what the surgeon should be looking into. Supremacid, it will be, the choices are like greater omentum, lesser omentum, mesosigmoid, and mesoappendix, etc., etc. Mesoappendix. So, you have to understand how this particular thing is important, because this is going to be important. I will be coming to discuss more about this particular mesoappendix and the blood supply to it. So, this is about this particular appendix, and the length of the appendix is variable. It is like 5 to 9 centimeters, which is present in a normal conditions, and this particular appendix, inside to it, it has a lumen. It is not a blind one, it has a lumen to it which is narrow, and within this particular lumen it is covered or having some lots of lymph nodes are there. That is why this particular area which is filled up with the lymphoids, right. So, this particular area, that is why you call them as abdominal tonsil. So, that is like tonsil, there are lots of lymphatics are there present within it, and this particular appendix having lot of like a rich in nerve supply, rich in kind of like a blood supply, rich in lymphatic drainage as well. Now, coming to this particular appendix, the pain of this particular appendix which is coming in is transmitted through spinal cord segment T10. Now, what does it mean? That means, if the appendix having a disease, that information of the disease appendix is going through, traveling through the spinal nerve T10, and it is following that particular T10 domain. Now, if you look at into this particular our body, so which is starting from the xiphoid process to the umbilicus to this particular pelvic region like this, our body can be divided into dermatomes. So, if you just like see this particular dermatome pattern which is running in across, a particular nerve is supplying. Say for example, is just like xiphoid region, like a xiphoid process which is supplied by this, I believe, T5, and this particular umbilicus region is supplied by the T10, and nipple area which is likely T4, but please cross verify which I am saying. So, T4, T5 is that like a xiphoid process, T4 is the nipple area around, and T10 is this the umbilical region. So, what does it mean actually? So, if this spinal nerve, that means T10 spinal nerve which is carrying this particular pain fiber, this T10 serves this particular skin domain into this particular umbilical region. So, if we carry this pain from the appendix, if it is carried through this particular T10 spinal nerves which is supplying the skin over this umbilicus, the patient usually experiences the pain which is arising of appendix at around umbilical domain. So, patient will be complaining of pain around umbilicus and explain why. The pain of appendix is felt by a patient around T-tame or around umbilicus. So, they want to know you understand this dermatome pattern which is existing on it. Whenever you are answering this, you have to explain this dermatome pattern about this which is supplying this particular area skin, T10 dermatome. The pain of the appendix is carried through the spinal nerve which is T10. So, if this particular spinal nerve is carrying the pain from the appendix, in appendix infection which is known as acute appendicitis or any appendicular disease which is related to it, which will be running through the T10 spinal nerves, and the T10 spinal nerves is supplying the skin over this T10 or around the umbilicus. That is why we feel the pain which is around this region, we call them as referred pain sensation around that part. So, this is why we call them as explain why pain of this acute appendicitis is felt over umbilicus, explain why kind of question. Explain the dermatome, explain the nerve which is following, and that is why this dermatome region T10 supplying through it, it is supplying in this region. So, this is what we are going to talk out here whenever we are going to talk about this particular pain of the appendicitis or related to this particular problem. Now, coming to the diseases of the appendix. So, appendix is having a prone to have infections. Now, there are some reasons why this particular appendix is prone to have infections. First thing is the appendix is a blind pouch. What do you mean by blind pouch? That means it is a dead end. So, it is a kind of like a ileocecal junction or ileal diverticulum where it is or ileocecal junction, this particular appendix or cecum has this out pouch, and this particular out pouch has a blind lane and a narrow lumen. Now, what it has? It is blind pouch and it is a narrow lumen. That means the cavity which is present through it is narrow. Okay. So, if you have an infection present in here which is blind out here, cannot reach far beyond this particular point, and you have tons of what? Lymph nodes are there. The moment you have infections, the lymph nodes get alarmed, they swell. So, they start swelling and they block the lumen. So, once they block the lumen, this particular thing swell up. Once this particular thing swell up, this mesoappendix also gets cramped. What mesoappendix contains? The blood vessels. The blood vessels also can get cramped. So, the flow of the blood is interrupted. So, no more rescue antibiotics etc., or any kind of things are coming. So, it is trapping over here and swollen and getting bad. So, that is why it is having a blind lumen, having kind of problem with this. Lot of lymph nodes are there, it can get cramped and edema can make these things worse and have prone to have infections. This thing can happen. Second thing, what can happen with this? The lumen is narrow. That means if you have a hard object pressing on the lumen, say if you have a hard stool which is blocked this narrow lumen path, again same thing happens. So, these things are blocked and the circulation through here is not happening. So, these particular things are having some kind of bacteria, germs normally present in case of the gut, that is replicating and increasing in number. So, that if you have increased bacterial count, these lymph nodes is also enlarging, the same thing happening. So, it is blocked out here and then we have this obstruction because of this hypertrophy of the lymph nodes, that is cramming this blood vessel and nothing is getting out of this. There is swelling, stopping the blood flow etc., etc. Same sequel can happen. So, this is one thing can happen out of these particular problems related to this particular appendix, right. Now, if you have an appendix infection coming to the patient, is coming to your clinic and you saying that, oh, you have pain abdomen, take this blue pill, oh, you have abdomen acidity, you take this white pill and go back and sleep, come back after 3 days. Now, what this particular appendix is going to happen? They are not recovering by you on its own. You are giving antibiotics, it is not reaching there because blood supply is less. You are giving pain medicines, it is not reaching there because low blood supply is there. So, pain is not relieved, neither the infection is, rather it is mounting high. So, what is going to happen? The patient is going to have lot of more infections here. So, the infection leads to disintegration of the lymph nodes. There are lots of fluid is coming out of. So we have a pus formation there. Dead RBC, dead WBCs, dead platelets, dead tissue cells accumulated over the pus. That pus is infected. Now this particular appendix is a blind lumen, it cannot stretch. Now this appendix can rupture, burst. We call them as burst appendix, and pus will be coming out of it. Where it will be removed, where it will be released, this pus? Blood sac, which is greater sac over here. So this particular greater sac will be infected. So these nearby organs will be affected as well. So is this peritoneum. So you have the peritoneal infections, peritonitis, etc., etc. It can trickle down to this particular pelvis. So it can lead to the pelvic infection. It can move up, go under the diaphragm, create a pus, and that particular point all over this particular abdomen it is spreading. After 3 days, patient comes back in shock, and you will be shocked too, seeing the patient, likely so, right? So this appendix is prone to have infections. Why this appendix have prone to have infections? How these particular infections can bring trouble if it is not taken care of at the early stage. So just giving antibiotics to an appendix is not enough. Sometimes you have to always do a scan. These things happen. Last time I checked one patient, that was my mistake too. So patient came from a peripheral location. They came with faith that I am a very good doctor, which I am not. Anyways, they came for it. So they was treating somewhere, getting the treatment from somewhere else, and they diagnosed acute appendicitis. They want to confirm it, reconfirm it. I say yes, acute appendicitis is there, but pain is subsided. It's no more pain is there. The sign of loss of pain actually comprehended by the patient is disease is no more, right? So I also thought of like yes, likely, but it could have another possibility. If the pus have formed, then if the pus have formed, they innervates the nerves and nerve become numb. So the pain subsidence is there. So that is another form. I said okay, yes, pus have, pain is not there. So might be you have recovered. So you are to check another scan. So the patient said, okay, whatever you feel like, do it. I said no, দরকার নেই আর ছেড়ে দিন। তারপরে কি মনে হলো আচ্ছা যদি ওই কেস হয়ে যায়, apparently দেখে পেশেন্টটা মনে হচ্ছে it's good, doing well, not toxic. But what I felt like okay, ওই possibility যদি হয় হবে না, তবু করে নিন। Good that I asked that to do a rescan. And again, what came with this rescan is a big appendicular abscess. Things have gone beyond. Then we urgently have to operate for it. We don't have any other choices. So we call them as appendicular abscess, which is because of the burst appendix. Pain has removed because of the lumen is open. No more stress. Blood can flow fast freely, and no more nerves are kind of like taking the sensation because it is already dead already, or maybe this particular nerve is numb by these infections. They blackmail these nerves. They chachasna. So things are like this. Abdomen is always a magic box, always gonna test you with surprises. So appendicular abscess, appendicitis, why this appendix prone to have infections, why this appendix ruptures, how this particular appendicular abscess rupture spills into which part of the abdomen, that's what you have to understand very well. Now coming to the blood supply of the appendix. Now the cecum and appendix is supplied by artery, we call them as ileocolic artery, ICA, ileocolic artery, that supplies ileal branch and colic branch. So this ileal branch and colic branch, we take this colic branch. So this colic branch going to supply, ileocecal branch, right? Sorry, ileocecal artery, it is going to be supplying ileal. So sorry, this cecum and appendix is supplied by ileocecal artery. They supply the ileum and they supply this colon. So this particular cecum and this particular cecal or cecal branch have got two divisions. They call them as anterior division and posterior division of the cecum. So they supply the anterior part of the cecum and posterior part of the cecum like this. So this cecum is supplied by this cecal branch of ileocecal artery, which is a branch of ileocholic artery. So this particular ileocecal branch or cecal branch, which has an anterior and posterior division, this posterior division or anterior division supplies this particular appendix. Posterior division? Posterior division. So this posterior division gives a branch to this appendix, we call them as appendicular branch. This appendicular branch or appendicular artery is present on this mesentery. That mesentery we are referring here. What mesentery? The mesoappendix. So this mesoappendix holds this particular appendicular branch which is going to supply the appendix. This appendicular branch has a trouble. What trouble it has? It is also an end artery. What do you mean by end artery? That means it has no friend, loner, speaks nobody, shakes nobody. So it goes to supply the appendix and job done, sleeps there. So this particular end artery is having a problem too. That means it has no anastomosis. If this particular artery is knocked out, we don't have any additional supply. So this end artery is having a problem as well. So if this artery is blocked by any chance, that's why he's saying, if you have edema compressing this artery, you have no replacement artery there to supply it. So this acute appendicitis is also having a trouble because of this blind pouch and as well as this end arteries. So both of them are troubles for us. That's why this acute appendicitis needs to be checked well whenever these things are coming on. So always do an ultrasound for this acute appendicitis or abdominal problems. Alright, that's a request. So acute appendicitis is because of these particular problems which is happening, and end artery phenomenon is also not helping out to deal with these particular diseases if these particular things have aggravated. So if it is under control, we have no problem whatsoever. But if it is going out of our hand because of the infections and anything, we have a big problem. Now, how we are going to identify this particular person having acute appendicitis? We do a clinical examination. We ask the patient to lie down, fold the leg and take long deep breaths. We know this appendix is placed on right iliac fossa. Now in the right iliac fossa, we point to find out a mark there. We call them as McBurney's point. Now we have to know what do you mean by the McBurney's point. MC, Burney, M, capital M, C and then big B, Burney's point. Now McBurney's point is measured from a line joining from umbilicus to ASIS. You know the ASIS? Okay. And umbilicus. You join a line, joining these two, a straight line, joining these two. Then we find this joint line split into three parts, 1, 2, 3. So we find a joining line which is medial 2/3 and lateral 1/3 junction. That means medial 2/3 and lateral 1/3 junction on that particular line where it ends that, or where this point is, we call them as that point as McBurney's point. So what is McBurney's point? It's a point located on the line joining umbilicus to ASIS. And that particular point is on that line on the junction of medial 2/3 and lateral 1/3. That means we split the line in three parts, the medial 2/3 and 1/3 lateral. That particular point is that point we call them as McBurney's point. Now what do? That particular McBurney's point becomes tender if we press that, if you have acute appendicitis. That means to ask the patient, lie down, find that particular point, where is the McBurney's point, joining the line, imaginary line, and press with your thumb or pulp of your thumb. Press there and release. The patient usually feels pain and rebound pain. Press it and take it out, it feels pain, and release it, also feels pain. So that means McBurney's point tender. Now by that particular McBurney's point, which part of the appendix you are touching? Appendix had how many points? Hip, body, base. So out of these, which part is you are touching? No, you are touching the base, because base is a constant part of the appendix. Hip is variable in position. It can be anywhere. This way, that way, anyway. right? So this particular point on the McBurney's point, where you touching? I don't hear you. Oh, base. Which you have weakness there? Base is weak or foundation is good? We call them as weak base. So that particular point, if you have a tenderness there, we call them as McBurney's point tender. That means it's a clinical sign. You're more likely to have acute appendicitis. Then go for scans and etc. etc. You can find this particular problem struggling with related to this particular point. Now quickly, whatever I've said, like quickly a visual thing which may be clearing your doubts and give you a better idea. This is what we are talking about. Characteristic of large intestine: sacculation, tinea, and appendices epiploicae or omental epiploicae or Tenia epiploicae, whatever things are called. These are nothing but the fat pouches, but you have to remember this particular features of the large intestine. This is must know about these particular features. And what do you mean by sacculation? What do you mean by the tinea? And how many bands are there? 3 of them. But at least you should be knowing this particular Tenia Coli, which is like a muscle band or kind of ribbon like band, and these fat pouches. These are fat pouches. These pouches we call them as Appendices Epiploicae. Then we have this particular blind pouch, we call them as cecum, which is having a valve in here. We call them as ileocecal valve, which is between cecum and appendix. Cecum and ileum. So it is lying in this particular part, which is separating this particular flow between the cecum and appendix, controlling it. And posteromedial to it, we find this particular blind pouch, we call them as the appendix or appendix. This is having a length of 3 to 9 centimeter, variable. It has a base where it is attached to it. And then we have the tip, and in between them we have the body. And then hanging between them, this part is a mesentery. We call them as mesoappendix. Clear? So this is how these particular things are existing on. The ileocecal valve, which is present in this particular region, which is present between the cecum and appendix. So this particular material can come from this particular ileum side going to the cecum, and the reverse thing is stopped. So this reverse flow between this part is stopped here. So this valve is guarding here, so that it is making a one-way channel of the food passage from this ileum, that means small intestine, to large intestine. From the large intestine to small intestine, the backflow doesn't happen. Now this is what we are talking about. This artery, ileocolic artery. This ileocolic artery splits into cecal branches, which is this anterior and posterior cecal branches. This posterior cecal artery gives a branch, we call them as appendicular branch, which goes to supply this appendix like this. So this particular appendix is supplied by this appendicular artery. This artery, what kind of artery it is? End artery. You remember this word, they want to hear this. It is known as end artery. What do you mean by end artery? They will ask you. You say that no anastomosis. It ends on its own. It is ending by its own. So no offsprings. Clear? Now what kind of diverticulum it is? It is a blind pouch diverticulum. That means the diverticulum also have a dead end. Nothing is communicating beyond. So one way there, going in, not coming back. We call them as blind pouch, blind. So this word also they look for, blind pouch. Okay. So this appendix having this kind of tissue which is present in here, we call them as lymphoid tissue which is present in it, and the appendix which is covered by this mesentery, mesoappendix. What do they contain? Vessels. That means appendicular artery, appendicular vein. They want to hear this. All these things are your exam questions that we are saying on here. So this is appendix which is involved, which is having infections. So it is enlarged and tender. So where this particular tender appendix will be pressing on pain, it's McBurney's point tender. McBurney's point, how we are going to find? This is how, on the right side, ASIS to umbilicus, junctions of right medial 2/3 and lateral 1/3 at the junctions where you are going to find this. Now if you are going to have this particular thing, we are going to press on that particular point. Which part of the appendix you are going to touch? Remember this base. the identification of the base of appendix, always remember, and tip is variable. Why this tip is variable? Because tip have got different directions to talk about. We are talking about different directions or different points of this point. So, this is how we are going to find. We find this particular 1, 2, 3 points, and joining this number 3 is the McBurney's point. Clear? How you are going to find this? ASIS to this point, and then if you make an incision and this, you call them as McBurney's incision. If you cut that McBurney point, we call them as McBurney's point incision. We call them as gridiron incision as well. But anyways, now these are the common positions of the appendix, which could be, most common is 64%. This 64% means this retrocecal. Remember that, that's the common thing. Then less common is pre-ileal and post-ileal, which is in front and the back of this ileum. Then we have this pelvic downside cecal and sometimes like subcecal. So, this downside position, cecal, subcecal and pelvic, which is the two things, and then we have this retrocecal position, which are like the common. Now, remember this, the position of the appendix is determined by, not by the base, it is by the tip. How the tip is directed? We name it. Appendix and this particular thing, which is running in this particular blood supply, coming to this particular point, and the pain of the appendix going through the spinal cord. Number 10, spinal nerve. Spinal T10 dermatome is on umbilicus. That is why the pain of the appendix is felt on the umbilicus. Patient will be complaining on umbilical pain, and they will have a tender McBurney point if you are examining it. Pain of the appendix, initial pain, appendicitis felt around the umbilicus region. Explain why. Right? Now see that later these particular things can get diffuse. So pain was initially felt at that particular point may get diffuse because of the spread of the infection. That is what we are coming into. So this was an appendix. This particular appendix was affected like this and not treated. It can burst open. Infected appendix can create a problem. So this particular infected appendix problem can lead to several problems, called them as appendicular abscess or appendicular abscellular mass or appendicular burst abdomen, etc., etc. Now, predisposition of appendix infection, that is what we are talking here. Why this appendix is prone to have infections? It is a long, narrow, blind pouch, that is what you are talking about, and this particular thing has got having this particular large amount of lymphoid tissues inside to it. So, if the lymphoid tissues gets enlarged, it is blocked. Again, if you have a hard stool pressing on like this, the lumen can be blocked. Again, it is the same phenomenon. If there is a blockage of these things, the small vessels and arteries which is present in it can be cramped. So, appendicular arteries which is having here is a blind end arteries. No anastomosis there. It may be end artery blockage there. So, this particular end artery blockage leads to having not having anastomosis, can lead to intense edema, and wall compression can lead to the appendicular artery thrombosis. That means blood is not flowing through that particular artery anymore. So, no blood supply, no medicines, no rescue point. So, this appendix is commonly have got gangrene, wall distortions and leading to the perforation. That means rupture thing. That perforation is these things leads to the spillage of infection to the greater sac and lead to the infections of the peritoneum. We call them as peritoneal infection, peritonitis. Spread of the infections can go to the pelvis anywhere. So, this particular thing is complicated with this abscess formation. We call them as appendicular abscess like this. So, normal appendicitis not treated, abscess formation could be there. So, acute appendicitis, if you are treating it like in this particular stage, fine. If it is neglecting it, can lead to this ulceration, can lead to abscess formation, can lead to so many troubles. Clear? So, explain why the pain of appendix goes to umbilical region. Explain why the appendix is prone to have infections. Explain why the appendix is prone to have ruptures, etc., etc. Explain why. Clear? So, this is what we are learning out here, appendix and large intestine.